If you want to know if your loved one with cerebral palsy in ICU, unable to wean off the ventilator with the tracheostomy, is able to come home with intensive care at home, stay tuned. I've got news for you. My name is Patrick Hutzel from intensivecarehome.com, and I have an email today from Amina, who has a family member in intensive care, her sister, her 40-year-old sister, with cerebral palsy. She's been in ICU for many months. She's got spastic cerebral palsy, seizure disorders, severe scoliosis, complicated by restrictive lung disease, had a tracheostomy in November last year to permit invasive mechanical ventilation. She has recurrent UTIs, which are urinary tract infections. She has a history of DVT and PE, DVT, deep vein thrombosis, and PE, pulmonary emboli, for which she is on apixaban, and she has dysphagia with gastroparesis. She's got a nasojejunostomy tube. She's on chronic erythromycin for motility, and she has a size 6 tracheostomy. She is in a pressure control ventilation mode with a respiratory rate of 18 breaths per minute, with a PEEP of 5. They have been trying some spontaneous breathing trials on pressure support ventilation, but they always have to go up with the pressure support and then put her back in the pressure control ventilation mode. So she has been failing the spontaneous breathing trials, unfortunately, which is not overly surprising in a situation like that. She went into ICU for recurring aspiration pneumonias, not necessarily respiratory failure. Prior to those aspiration pneumonias and the ICU admission, the patient was not on oxygen or positive pressure at all. But obviously now the situation has changed significantly. And whilst all efforts to wean this patient off the ventilator have failed, obviously the family has now reached out to us and asked whether she could go home with intensive care at home. And the answer is a clear yes, but I will break it down into more detail so that you can understand why we can take her home and how this compares to many of our other cerebral palsy clients or many other of our clients that are at home ventilated with a tracheostomy. Because it is not a novelty for us to look after ventilated adults and children at home with tracheostomies, but including cerebral palsy. Some of our clients are at home with cerebral palsy on ventilation with tracheostomy. Some of our clients are at home on BiPAP ventilation without a tracheostomy with cerebral palsy. The family still has many questions. Some of them are that her pathology and bloods are taken every 2 to 3 days. But based on the last result, do we think she's getting an infection, or why is her white cell count getting high? Yes, that her white cell count is getting high and that she probably has an infection with her recurring UTI, but also potentially another chest infection. Here's the thing. We can take bloods at home every 2 to 3 days. There's no issue around that. And bear in mind, one of the reasons why patients in ICU get an infection is because they are in a quote-unquote dirty environment, because they're surrounded by other sick patients that are spreading bugs, and that is clearly one of the reasons why she's getting recurring infections at home. That will all go out of the window because it's a much cleaner, well, a clean environment, as a matter of fact. Will she continue to take blood pressure medications? Yes, she will, because unfortunately, she's moving sort of slowly into mild heart failure, which is not unusual for patients with cerebral palsy. Other things that the family is concerned about, how can we follow up about any medical issues at home once she's out of ICU with intensive care at home? Well, once again, there is no issue around that. Medical issues can be escalated to your family doctor, to your GP, or to your respiratory physician. We can also organize an intensivist at home, so there is no problem. Now, other questions that the family has is, my sister normally wears a scoliosis support brace and then sits up in a wheelchair. I said that this is going to be needed to take her home so she can improve her digestion and her gut motility, but also her mobility, but also that she can get transported, digest better, and breathe better. And that is absolutely accurate. Many patients, unfortunately, with cerebral palsy need such a brace because they do have scoliosis, and they do need the brace. They do need to get mobilized to improve their mobility, their gut motility, their digestion, their ventilation. All of that needs to happen. And also, it's about community access. One of the biggest difference with intensive care at home compared to a long-term stay in ICU is all of our clients, without exception, have community access. Compare that to an ICU bed where patients stare at the wall for 24 hours a day, which drives them insane. There's no quality of life, and that is the big difference, or one of the big differences. Then family also says that her belly is very distended, and with the tracheostomy tube feed, she's draining bile through the nasogastric tube. And the doctors say until her distension comes down or digestion improves. Well, two things to that. She hasn't been mobilized, which, is not helping her digestion. If she's draining out bile and she's not digesting the NJ feeds, and also she's losing weight, because that's part of the question from the family, she's losing weight. Clearly, she needs to have TPN as well, right? Also, the doctors say that the white cell count is likely from inflammation and from previous infections, because her current oxygen levels have been good, and she has no fever. Also, the cardiac echo or the heart echo has shown that she has heart stiffening, which is a new thing for her, but it's also unfortunately common for patients with cerebral palsy to end up with some form of cardiomyopathy or left ventricular dysfunction. Unfortunately, that is not new. But again, that will not stop her from going home, not at all. Also, the family is asking if low sodium can be treated at home, and high sodium or low sodium can be treated at home, because she had high sodium because she was dehydrated, and that was managed with water flushes, and sodium is now back to normal. And the patient needs nutritional reassessment prior to discharge. Like I said, TPN will need to be discussed here. Also, potassium levels are low at 3.3. This also needs to be addressed, but once again, we can do potassium infusions at home, but what she needs is a PICC line or a central line or a Hickman's line or a port before going home, because that is something that needs to be replaced on a regular basis, right? So, and like I said, ventilation weaning can be done at home once she's out of the quote-unquote dirty ICU environment, where she's only getting hammered with infection after infection after infection, because so many other patients would spread the bugs around, right? Also, what needs to happen for home care? She needs a home care ventilator, suction machines, monitors, home care bed, a hoist, which I believe she already has, right? And obviously a team that we can hire, that we will hire for you. And the funding needs to be in place, but that's the least of my concerns, because someone is paying $5,000 to $6,000 for the ICU bed per day at the moment. Let me repeat that. Someone is paying $5,000 to $6,000 per bed day in ICU. So to bring that down to half of the cost, which is what intensive care at home is a no-brainer and is a win-win situation. Now, because the patient also has seizures as part of the cerebral palsy, she's also on the following medications: topiramate 50 milligrams BD, Keppra 500 milligrams 8 hourly, lorazepam 0.25 milligrams 2 hourly PRN if needed, if there are consecutive seizures or seizures lasting for longer than 3 minutes or multiple continuous seizures. She's also on baclofen and melatonin for spastic cerebral palsy. She's now on amlodipine as well for the stiffening of the heart. Metoprolol was stopped. She is hemodynamically stable at the moment. So part of the issue with not being able to wean off the ventilator is the severe restrictive lung disease from the scoliosis. And there is chronic hypoxemic and hypercarbic respiratory failure on ventilation. I've gone through the ventilator settings earlier. So in many cases, this situation fits exactly the picture that many of our other clients are fitting at home, with the difference that this lady might need TPN. But once again, we're also running multiple TPN, home TPN programs. I've been running them for many years, so this can all be done. I think it's really time for your sister to go home as quickly as possible. And this is why we are so uniquely positioned for this niche market, where we can take those complex patients at home and improve their quality of life so quickly, that ICU simply can't do, because, patients are stuck in an ICU bed, in an ICU cubicle, with no natural daylight, where patients only stare at their wards 24 hours a day. And there's no quality of life. Why would patients and their families needing to be exposed to such an environment if the same level of care can be provided at home? So with intensive care at home, we are currently sending our critical care nurses into the home 24 hours a day. Therefore, we are providing a genuine alternative to a long-term stay in intensive care for ventilation and tracheostomy, home BiPAP, home CPAP, ventilation without tracheostomy, tracheostomy care at home without ventilation, all for adults and children, home TPN, home IV potassium, home IV magnesium infusions, IV fluids, and IV antibiotics. We're also providing ventilation weaning at home. We're also providing central line, PICC line, Hickman's line, as well as port management at home. We're also providing nasogastric tube and PEG tube management at home, as well as nasojejunostomy tubes or PEG tubes management at home, as well as palliative care services at home. We are also sending our critical care nurses into the home for emergency department bypass services. We have done so successfully as part of the Western Sydney Local Area Health District, their In Touch program, saving approximately $2,000 per patient that we keep at home instead of them going to an emergency department. Therefore, we're also in a position to cut the cost of an intensive care bed by around 50%. An intensive care bed costs around $5,000 to $6,000 per bed day. Our service costs between $2,500 to $3,000 per bed day. And we're freeing up the most sought after bed in the hospital, which is the ICU bed. But most importantly, we're improving the quality of life for patients and their families, which is a win-win situation for all stakeholders. With intensive care at home, we are currently operating all around Australia in all major capital cities, as well as in all regional and rural areas. We are an NDIS-approved service provider all around Australia, TAC and WorkSafe in Victoria, iCare in New South Wales, NIISQ in Queensland, as well as the Department of Veteran Affairs all around Australia. Our clients and we as a provider have also received funding through public hospitals, private health funds, as well as departments of health. We are currently the only service provider in Australia that has achieved third-party accreditation for intensive care at home nursing in 2025. We have been achieving this level of accreditation since 2012. No other provider has achieved this level of accreditation in the community and has created more intellectual property when it comes to intensive care at home nursing than we have. This puts us in a position to employ hundreds of years of critical care nursing experience combined in the community. No other service provider in 2025 employs a higher skill level in the community than we do, which enables us to look after the highest acuity adults and children in the community in Australia safely. If you're at home already and you realize you don't have the right level of support, or if you're stuck in an ICU long-term, or if your family member is stuck in an ICU long-term, I'll give you a real-world example today. One of our first clients about 10 years ago, when we first got started, was a client who was at home initially on a ventilator with a tracheostomy with the support worker model 24/7. Of course, it is dangerous and negligent having support workers looking after a client at home on a ventilator with a tracheostomy. That is like flying the airplane with the cabin crew instead of the pilot. because anyone on a ventilator with a tracheostomy is at very high risk of medical emergencies or even dying if they don't have a team of critical care nurses looking after them 24/7. This is evidence-based in the community and is documented in our mechanical home ventilation guidelines that you can find on our website at intensivecarehome.com, where it's clearly documented that only and exclusively critical care nurses with a minimum of 2 years critical care nursing experience can look after ventilation and tracheostomy at home safely. Think about it. In an intensive care unit, in a hospital, you wouldn't have support workers looking after a critical care patient on a ventilator with a tracheostomy. So why would anyone in their right mind would do that in a home care setting in the community? People have died because of this support worker model for ventilated and tracheostomy clients. People have died without a ventilator and a tracheostomy with a support worker model as well. So eventually, this client found out about us and the ICU that he was going back to found out about us. We were proving our concept with this client very fast. When we worked with the client, we sent him intensive care nurses 24 hours a day. And he never ever went back into ICU ever again. And we were proving our concept there very fast. We can do the same for you if you're not safe at home, which includes the advocacy for funding that goes along with it. We have always successfully advocated for our clients since 2012. Otherwise, we would not be in business. The same applies for those stuck in an ICU, similar to our to this particular patient, to what you're looking for. Reach out to us. We'll make it happen for you as well. We can take you through the right steps. This is also why we're providing level 2 and level 3 NDI support coordination. We have a team of NDI support coordinators, and they have a wealth of knowledge. I've done an interview with Amanda Riches, one of our NDI support coordinators, and I'll put a link to an interview with Amanda in the written version of this blog below the video. We're also providing TAC case management and WorkSafe case management in Victoria with Lucy McCotta. If you're an NDI support coordinator or a case manager from another organization watching this and you're looking for nursing care for your participants, please reach out to us as well. If you're looking for funding for nursing care for your participants and you don't know how to go about it and what evidence to provide, I encourage you to reach out to us as well. We will help you with the right level of funding, and with the right level of advocacy, we're also providing NDI specialist nursing assessments done by critical care nurses with a legal nurse consulting background. If you are a critical care nurse and you're looking for a career change and you want to join a very progressive, dynamic and high-performing team of critical care nurses in the community, we're employing hundreds of years of critical care nursing experience combined. If you're looking for a career change, we're currently hiring for jobs for critical care nurses in Melbourne, Sydney, Brisbane, in Albury, Wodonga, in Bendigo, in Geelong, and in Warragul in Victoria. If you have worked in critical care nursing for a minimum of 2 years, pediatric ICU, ED, and you have already completed a postgraduate critical care nursing qualification, we will be delighted hearing from you. I have a disclaimer, because we are offering a tailor-made solution for our clients, which includes regular staff. Our clients do want the same staff coming over and over again because they are so vulnerable and very special, and that's why we need regular staff. So if you're looking for agency work where you can come and go, this will not be the right fit for you. We are looking for consistency, and our clients are looking for consistency. So please only apply with us if you can give us regular and consistent availability for shifts, and if you're really keen on building relationships with us and with our clients. And if you're an intensive care specialist or an ED specialist, we also want to hear from you. We're currently expanding our medical team as well. We can also help you eliminate your bed blocks in your ICU and in your ED for your long-term patients or for your regularly readmitting patients with our critical care nursing team at home. We're here to help you take the pressure off your ICU and ED beds. In most cases, you won't even pay for it. Even if you do pay for it, it is so much more cost effective than what you're paying for in ICU and ED. And you get the same level of care, and we're freeing up your beds. If you're a hospital executive watching this and you have bed blocks in your ICU, ED, respiratory wards, home TPN, please reach out to us as well. We can help you eliminate your bed blocks very fast. If you're in the US, in the UK, and you're watching this and you need help, we want to hear from you as well. We can help you there privately with one-on-one consulting and with hiring nurses privately. Once again, our website is intensivecareathome.com. Call us on one of the numbers on the top of our website, or simply send us an email to info@intensivecareathome.com. If you like my videos, subscribe to my YouTube channel for regular updates for families with intensive care at home and intensive care. Click the like button, click the notification bell Share this video with your friends and families and comment below what you think about this video and what you want to see next. Thank you so much for watching. This is Patrick Hutzel from intensivecare@home.com. I will talk to you in a few days.